Hi, thank you all for being here. We're thinking of organizing this Q&A broadly into three sections. One being applying into IR and what that looks like, the mechanics of it. Two, once you're in the residency, how can you develop and expand these skills? And lastly, kind of more speculation on the future of IR residencies in the field broadly. So I thought we'd start out first with kind of a broad question. This is directed towards both a West Coast PD and an East Coast PD, so Dr. Meisinger and Dr. Bryce. What are qualities you look for in applicants, and how can applicants portray this in their application?
Do you want to start first, Dr. Bryce?
Oh, sure. Well, thank you so much for inviting me. I'm honored. So I have an independent IR residency. I don't have an integrated. So I'm looking at candidates that have done radiology already, or about to complete their radiology training. And really, what I look for in a candidate is someone who has been strong throughout their whole educational experience. So medical school, what their rotation comments are like, and what the different evaluations are during radiology. And then I really focus on the letters of recommendation. I personally like to see that somebody has mentioned that they're very hard workers. I feel as if they're very hard workers, I can teach them anything, but if they're not hard workers, I think there's not much I can do for them in that. I do look at board scores and volunteer work, and leadership, some kind of leadership positions that they've had. So I kind of look at the whole picture. I rely a lot on evaluations of rotations and letters of recommendation above most other things.
Yeah, I definitely agree with everything she said. I think when it comes to specifically medical students, I really like to get into the MSPE, the Dean's letter, about what your work ethic is like on rotations, even if it's all your third-year rotations, even if you're on psychiatry. If they're saying that you're working hard and staying late, I really like to see that you get along, you're a team player, you're malleable, so you fit into different teams depending on the structure. So I really like to get into the specifics of what they say in the Dean's letter about you and your rotations, particularly during the third year when you kind of have to be on it.
And as a follow-up to that, as step one is transitioning to pass-fail, how is that changing how applicants are being kind of evaluated?
I could start with this one. This is a big change for all of us, of course, right? So step one really provides your academic standing, in my opinion. It kind of gives me a baseline and says, how good are you going to be at test taking, right? And so in radiology, the core exam is very important. It's taken at the end of your third year, and that's essentially a step one in a more specific radiology term. So if you do well on that, then generally you're going to do well on that specific test. So I think just shifting more to a step two based use. So I'd prefer if most applicants had a step two, just to provide me on how good of a test taker you are. But with that said, it's still kind of a work in process on how we're transitioning from step one. I don't know if, now that we don't have it, I don't really think it's going to change our holistic review. We don't really put too much emphasis on it anymore, but I still would like to see at least a score, knowing that you can take a standardized test. So I'm in favor of at least having step two scores.
I agree. Unfortunately, I know that taking away the step one score was supposed to be something towards moving less stress towards the applicant, and because we know that med school is very stressful, and I think it was supposed to unburden some of that and have people focus more on other things. I do think that there is value in seeing a score. I think also for people who are coming from less known programs and programs that are traditionally not well recognized. I think there is a value in having a score and a good score at that.
Now, to Dr. V and Dr. Cooper, what are some aspects of programs that applicants should take into consideration, such as exposure to clinic, practice environments, caseload? How might applicants best prepare for how to select a program?
Kyle, you want to answer first? Go
Yeah.
ahead, Kyle.
First off, sorry, it's a little loud. It's my son's birthday. I am at Disney. But this is the quietest place I can find. I think that the things that you need to be looking for in a program, first, no, not every program is going to have exposure to vascular disease. And I think that that's something that you should be looking for. That makes a well-rounded program. I think that you need to be looking for a program that does that inside of their own department if possible. Obviously, I'm a big proponent of doing vascular work. I think you have to have clinic, and the ideal setting would be something what Dr. Vatakencherry has, which is longitudinal clinic throughout the fellowship, a clinic that you see the resident sees their same patient over and over again. That's not always doable. So, but clinic it needs to be throughout the entire if possible. I think that there needs to be an admitting service. If you could admit patients to your own service, I think that's incredibly important. So, not every, we do urologic interventions like PCNL access with the urologist and they admit them to their service. There's nothing wrong with that. But if I admit a PAD patient and I'm trying to, compete against vascular surgery, I don't want to admit that patient to vascular surgery. They wouldn't try to steal it from me, but it's kind of poor form. So I admit those patients to my own service. We take care of them. The list goes on and on, but I want to give Dr. Vatakencherry a chance to talk and bounce off each other.
Yeah, no, I mean, I think with Dr. Cooper, the fact that he's here on his son's birthday at Disney is a testament to the passion that he and others have for being here on a Saturday morning, and kudos to him, and I appreciate that. The sacrifices that they make for the future of our specialty and future medicine is pretty profound. So I appreciate everyone on this conference call this morning. No, so as far as what I think is important is you have to figure out what you want, but I think service line construct, definitely admitting as the field is changing to comprehensive clinical care and longitudinal management, clinic is paramount. You need to have a clinic. You need to see the patient's initial for guidance and counseling. You need to follow them. So if that is not there and it's an order entry kind of process, I personally wouldn't advocate that. You need to see the consult. And then ideally, as Dr. Cooper said, no one's going to be more focused on taking care of the patient as you as the physician doing the surgery. So admitting to your service. And if you don't feel comfortable, consult another service, medicine or cards or whoever, but you kind of be the gatekeeper. That care is an important construct as well, in my opinion. And the various service lines, like most places will have hepatobiliary cancer, right? Very few places won't. But the things that Dr. Cooper is doing, such as complex CLI, et cetera, may not be offered, complex venous reconstructions, et cetera, the scope work that you see at UW, the musculoskeletal intervention, UCSD. So also look at those service lines. And if they don't have one, are they planning on building it or establishing it, right? I mean, Dr. Bryce has done some amazing work in developing the vascular lab and getting PD referrals in a place that historically hasn't had that. So I think these are very important initiatives. And you have driven people like that who are not like, oh, we can't build that service line, it's lost, but have them the drive and motivation to go, no, why not? We can go grow that. We're going to grow it in a competitive environment. That's where you want to go. Because if you learn that, how to be in the red ocean, the blue ocean will be a very easy.
I'd like to follow up on one other thing. You cannot be a good IR without being a good DR. And so I think you need to also evaluate what's the strength of the DR training at the program. I know B is very passionate about this as a DR PD for many years. Do you have independent call? Can you sign off on a report overnight without an attending looking at it 5 minutes later? Do you have the full complement of imaging modalities? What's your level of autonomy as you progress through? Are there a lot of fellows there that are going to take the high level cases from you on imaging? Those are all things I think that are also very, very important. I love DR. I don't do much of it anymore because I'm 100% IR and I have an academic day doing all the administrative work, but I miss it. And it makes you, I think the best DRs I've seen are IRs because they know how to make a call and come down strong on a finding. And so I think that's an important thing you need to be looking for.
So I'll put a caveat to that. So one of the things that I've recognized is we don't do echocardiography. We don't do a lot of cerebral angiography. So any surgeon, like if you look at neurosurgeon or neurointerventional or a neurologist, they're better at cerebral angiography than most radiology graduates because they don't do cerebral angiography. So whatever organ you as a surgeon are doing, doesn't matter if you're open surgeon or endosurgeon or an interventional surgeon, you have to own it, right? The scope work that we're doing now has nothing to do with the radiology. It is optical visualization of the pathology. That doesn't matter. You as an endoscopic specialist or endoscopic surgeon, like, you know, what the work that's being done by, that you saw by Jeff Chick, you have to understand biliary pathology, what it looks like intraluminally. So whatever surgery you're doing, whether endoscopic, which is no x-rays, or interventional operating, you have to understand the anatomy and pathology, and you have to understand the different imaging modalities. So I think that's the key. Any organ. Now, what radiology does is teach you anatomy and pathology head to toe in the most efficient fashion, right? That's why we can do head to toe interventions, because you learn anatomy and pathology. That is the crux of what you need to know as a surgeon from working head to toe. All right.
Now, this next one is for Dr. Luhar. We saw you address this in the chat a little bit. How can you stand out in applications if your home school doesn't have a VIR program?
Yeah, I think especially as we move towards broadening the number of medical schools we have, we're going to see new institutions that don't have the same level of exposure to the field of radiology specifically, and in particular to interventional radiology. So as somebody who has an interest in interventional radiology, or even in just getting to know it better, I think it is really important to be proactive in seeking out these opportunities. And there are national and local resources available to you, whether it's reaching out to local programs at private or community hospitals that may not be affiliated with your own medical school, whether it's reaching out to regional resources through, say, a radiological society, or very importantly, through getting plugged into the SIR RFS. I know I've interviewed multiple candidates whose primary exposure to the field of IR has been at places that are not their home institution, and have really managed to cultivate a strong network through the SIR RFS, through following leaders of the field on Twitter, et cetera, to the point that they're able to accomplish some really interesting projects, research, and to get a really meaningful idea of what it means to be in the field. I think my concern when I see an applicant who's interested in IR and who's matching into an integrated program, but does not have IR at their home institution, is really a concern that they don't understand what the field is or what it entails. And so what I want to see is that you have gone out of your way to really get to know what it means to be an IR. And now that you have that knowledge, it's something you wholeheartedly want to pursue.
I think that's a great segue to a couple questions coming in about away rotations and how you might get exposure in terms of the day-to-day clinical practice.
I'm sure any of the program directors on the chat can attest to how important the away rotation is, particularly in radiology residencies, which can be relatively small compared to other fields. You really want to feel like you can work well with the people coming into your institution. They're an important part of your own clinical excellence and to your team functioning well. So we certainly do really strongly consider the away rotation accomplishments of our visiting medical students as we are, reviewing applications and interviewing. And I think if you are interested in a specific location for residency, it really is an important asset to go do an away clerkship there and to really, 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 do your best to impress while you're there.
Yes. And I think the key, as Dr. Luhar says, is to do your best and to impress, because a lot of times when we have to solely rely on the interview, anyone can be on their best behavior for, a few hours. And so it's always hard to gauge, but for good or for bad, an away rotation is a very good way to gauge. And so you have to use that away rotation, because basically the away rotation is a very long interview, and you have to show up very early, stay very late, make sure you try to do some kind of, even if it's a case report, that's always, or you just have to go above and beyond. It's a very long interview. So I agree.
I put this in the chat, but reweight them pretty heavily. We'd like to know that you work well with the current residents, and we use a lot of resident feedback to say, how's the process gone? How have they been on rotation? Have they helped? Do you think you would get along with them? Would they make a good future resident? I think that really plays into a huge role for us.
Next question from the chat is, if you have a lot of research in another field and then discover IR a little bit later, how is that viewed? And should people maybe do a research year or something like that to get more exposure and research?
I was actually asked this just the other day by a medical student who's just come into interest in IR. For me, someone who has done the effort and been published, I think it goes a long way. But what you need to be, and I think it's, for me at least, when I'm looking at that, to me, that just shows a very good work ethic and the ability to push forth a project to the end. And I think it's a good thing. The one thing I would suggest is, even if the research is in another area, you have to be able to say how you could potentially integrate that you were focused on into IR. Let's say you were interested in nuclear medicine and you did a lot of nuclear medicine publications. How can you combine nuclear medicine with IR? Or urology, how can you combine that with IR? I think you should be able to defend it and to say how you could integrate it. But to me, a lot of publications shows that you are able to see a project through, which is not very often in the grand scheme.
Yeah, I agree with her. I like to see the initiative. I like to see that they've done research. That's great. And particularly when it comes to completing projects, if you do get something published, that always is a huge sign, not just current projects in motion. But yeah, everybody gets the IR at a different time. So I don't dock any points or say anything. It's all good stuff. All research is good.
So I'm seeing a few questions about ESIR, early specialization in IR versus integrated. And Dr. Bryce, as you were talking about, for someone who's newly kind of interested in IR, but maybe not sure, ESIR is always an option. It's not a binding commitment. So how do you evaluate between whether you want to go between the ESI route versus the integrated route? What are the strengths and the pros and cons of going down those roads?
I think I only have an independent IR residency. Maybe someone who has both types of programs should probably answer.
I mean, I'll definitely weigh in. We have probably one of the more integrated IR programs, so I can see the fundamental difference. The classic kind of ESIR, and we're talking about the national level. We may, there's a little bit of discontent when it comes to ESIR at the program director level, and we're going to talk about it in our upcoming APDR meeting. But having a lot of feedback from a lot of faculty, there's some concerns. ESIR is very variable throughout the country, and the people coming in, a lot of PDs have expressed concern. So it may or may not exist in its current fashion. We'll see, right? This is kind of something we implemented years ago to respond to the small community programs that did not have integrated training programs or did not have IR fellowships. And that was why we established ESIR. But ESIR's limitations is you need 500 cases, very non-specific as to what the requirements are. There's no quality assessment or quality assurance. And so if you look at our program, even if it's at our program as ESIR, it's just different, right? Because our residents get a half a day of clinic a week starting PGY2. They do surgical internship. They're doing VR calls at PGY2. Austin did last week, and Call was doing splenic, angios and embos, as a 2, doing consoles at a very high level. So you just can't compare the two, the way it's moving. And I think it'll continue to evolve in that fashion. I think we're making a lot of mistakes as a specialty, but we're learning from them, right? It's okay to make mistakes. Just like even as we run this program today, we've made some mistakes, but we're going to learn from them and get better. No different in our integrated training. We're going to see some paradigms. There's a lot of attrition right now from ESIRs or even integrateds because we haven't figured these things out. So I think that's something you'll have to understand, and it's a work in progress. But right now, the way the system is broken down to 3-2 model in most places, that's evolving as we get feedback from integrated trainees that they want more integration, they want less DR call, they want less VIR call. So we're going to see that as time goes on at more and more programs. And many of the kind of the students on here are gathering that data, so we have more objective criteria what that looks like. So I do think there's a difference. I think we're seeing that nationally. I'm curious to see if others want to vocally say that they see the difference, but I've heard it at least anecdotally from multiple PDs at a few meetings, including AIR, and whoever the students were at AIR probably heard that conversation as well from the PD panel.
Yeah, I think the overall issue is that we in the integrated pathways control your training from start to finish. And so Georgie kind of hit it nail on the head, is that ESIR, you are underneath the DR for the first 4 years of your training until you transition to an independent, and then you're under an integrated, you're under a IR specific PD. And so that's really the main difference for us. I think that I will kind of err on the opposite end of the spectrum and say our ESIR program thus far has worked really well as a feeder system into our independent. And I've found that our integrated and ESIR residents are pretty much equal with regards to their training. That's because there's a good relationship between me and my DR program director colleague at my institution, but that's variable across the country, right? So if you're coming to me and asking me, hey, I'm a little undecided between IR and DR, what should I do? I'd say, well, you should probably go through the DR route and pick a good ESIR program or a good institution that has a good ESIR program set up. So Georgie's right in saying that it is variable across the country, and he is right on the APDIR, kind of the leadership component of us. We're concerned going forward because of the high variability, whereas the integrated, there's not as much variability. So, but you have to be selective when it comes to your ESIR program.
I just want to mention that my program receives, I'm a Memorial Sloan Kettering Cancer Center, and we're an independent program that receives applicants that have done ESIR and those that have done just a regular radiology, and then they come to us and do 2 years. So we accept a 1 year and a 2 year. And I must say that a lot of times the people that come and stay for the 2 years end up much stronger than the ones that did the ESIR and come and just do 1 year with us. And I do want to say that there are multiple pathways to get into IR now. There are multiple pathways. And for those who are not able to get into an integrated program, I think there is value in trying to therefore try to get into a strong radiology program. If they have ESIR, great. If they don't have ESIR, it's still okay. Just get into a really good independent. I'm just saying there's multiple pathways, and I have seen advantages of some over others. I do think that there is a benefit in getting into actually a good radiology residency over a mediocre integrated program. I have seen I'm not putting any programs down, but I'm just saying as we go through these different pathways and more information is coming on and what makes a good program, the ultimate goal is not just to get into an integrated. And if you happen not to get into one, it's not the end of the world for you. You can still do get into an amazing program, and you can still be an amazing IR doctor.
I always kind of joke about the fact that, when I was sitting in your shoes and I interviewed at Ohio State, he asked me if there was any part of radiology that I liked more than others. And I said, honestly, I like them all, probably anything but IR. And, you can, there are differences. I agree with Dr. Vatakencherry, especially at some programs, there can be a big difference. But I would echo Dr. Meisinger in that ours is literally identical, because I have a very good relationship with my DR program director. We identify very early who is going to be in our ESIR pathway. We change around their call responsibilities at that time, and we start bringing them into clinic more. And at Loma Linda, at least at the moment, we actually have an ESIR spot where they're matched into DR, but already in the ESIR in their R1 year. And so I don't know if we're going to keep that or not, but at the moment we do something like that too, and they're indistinguishable for an IR integrated resident. So,
are there good ways to evaluate when you're looking at programs, how well DR and IR talk to each other. You all have commented on how you have good relationships with your DR colleagues as well.
I can take it if, you know, I think it comes down to really your interview time with the DR program director when you're coming through. So all of our IR applicants interview with both the IR and the DR program directors. And I think you just need to know what the division of labor is and how, what the setup is like and who is really controlling your IR training. So if it comes down, if you want more or less, or you want to have some variability, or for me, more recently, we've had ESIRs who are interested in going down the neuro IR pathway and how to facilitate them into subspecialty training in PEDS IR, which I have a couple with somebody interested in my program. So the two of us have to work and be able to say, if the IR training is not adequate for somebody, how do we alter this and allow you to be more flexible? So if they are not willing to do that, or that there's some service requirements on the DR side, then that should probably come out in your interview with them, in your discussions with them.
Dr. Luhar, can you comment?
You may hear more of my 2-year-old than me, unfortunately. I apologize. He's just extremely vocal on how much he loves the field of interventional radiology. He's also trying to kick me out of his room. I will say that, you know, for us, our ESIR program, I think, is very robust, in part because once we see that interest, we essentially treat them like our IRs. We work very closely with our DR colleagues, and there's essentially no real difference if you really look at the training between our IR integrated and our ESIRs. It's really just the point at which they commit to the field. So we have extremely strong graduates coming out of our ESIR pathway. And as I mentioned in the chat, I think that's why it is so important to assess not just whether or not a program has ESIR, but what is the quality of that program if you are considering it. Because you may not know if you want to do IR or DR when you match, and you may decide to go the DR route with the knowledge that you can jump to the IR pathway at this time. But if you find yourself in an institution without a strong ESIR, I do think you do yourself and your personal development as an interventional radiologist a disservice.
So transitioning into kind of what training looks like once you're in an IR program, how do your residents, particularly in their diagnostic years, maintain their clinical experience, advance their kind of surgical skills, interventional skills that become necessary in the IR years? Direct this one to Dr. V, Dr. Cooper.
Yeah, I mean, I think I'll just kind
ahead.
of quickly say it. So I think clinic, right? So the key thing that I've seen that our trainees learn the most from is from seeing a patient, take an undifferentiated problem, and guiding counsel the patient on what to do, right? Not a pre-op clinic, not a post-op clinic, but a clinic where they're telling them what to do. They learn natural history and follow-up over 5 years. So I think why Karthik is so good as a graduate, and I wish I had that kind of training. He's been seeing patients for natural history that I've been following for 10, 15 years in our clinic, and he's been following them for 5 years. And that is something that's a paradigm shift. So I think that if it's first 6 letters of clinician is clinic, right? So if you own the clinic, the rest will follow. Comprehensive clinical care is the key to our specialty's future. Everything else is important, sure, but like technically, I don't think there's much interest in ESIR, independent, 1 year, 2 year. I think volume, you'll get it in a year. I've trained countless fellows, and they're all pretty good technically, but how many of them can go out and build a practice or practice clinically? Exceedingly few. But the 6-7 year integrateds, they do pretty well. They're the handful that can go out there and succeed and build a practice, at least in my experience. Or if you get lucky enough to go to myovascular, you can go anywhere and build a practice, but that's pretty rare. You're working 3 years in one. And you know, there's a handful of places that have that kind of rigor, but it's hard. All right, Kyle, go ahead. Let's see what your counterpoint is.
It's not a counterpoint. I agree with you. I just, not every program has the capacity to do what you've done at your clinic. We all need to be striving towards it. But until then, on a more practical standpoint. I think that every patient you see patients and you get an opportunity to do procedures on all rotations. The question is, how clinical do you want to make it? Do you just want to go in and put in the NG tube, or do you want to talk to them and take a quick history? Do you want, you don't be afraid to do a physical exam before you get ready to do, a sulfur colloid injection for lymph node injection, for example. There are plenty of opportunities when you're seeing these patients to take a proper history and physical and to continue to keep those skills up. I think, on our ER rotation, there was an opportunity to go down and because we were very close to the ER, when I saw something that was equivocal, I would go down and I would see the patient and try and figure it out with a clinical exam, because I absolutely hate the word clinical correlation advised when you can do it yourself. I think that the ICU month is very helpful, but I think there is opportunities for elective time in many programs. So you can do like what we did in my training program, which we had a month of GI, a month of hepatology, and a month split between surgical oncology and medical oncology. And so looking for programs that have non-IR clinical and non-ICU clinical rotations. Vascular surgery is another common one. That's another opportunity to keep those skills up, but don't just be a fly on the wall in those rotations. They will often, like on vascular surgery, they're like, oh, okay, you're a PGY5. Yeah, you're running the service. And that makes people a little bit nervous sometimes, but no, you know how to run a service, and there's help with the fellows and with the PAs to do that. I think you should, lean into that opportunity.
Dr. V, can you talk about your clinic? What do you do in your clinic for the residents?
Yeah, so basically they do a half day. So the 2 does Monday afternoon, the 3 does Tuesday morning, the 5 does Friday morning and the 6 does Friday afternoon. Historically is what we do. So they have their own panel of patients that they follow, that they've either seen initial and follow over time. So for example, like Zaim has a patient who he read the scan or something, Nukes found a forcing to triple iliac aneurysm. So he's saw the patient, corresponding, getting the genetic workup and doing all those things. And then, he may not even be involved with treatment, but that's his patient. Just as one example, visceral aneurysm. So they just see all the different kind of diseases and they follow them over time. They may not have done the procedure, but they learn the natural history of what happens. Or if they've done a TIPS, they see, oh, let's follow them 6 months, look at the imaging, let's look at the labs, reorder the rifaximin or what have you, or stop it, or, et cetera. So that's been gangbusters. And then anything that I don't do, that we don't do, we'll send them to the clinic. So when when I'm on call, I don't have clinics, or they don't have clinic, then they'll go to the urology clinic, they go to urodynamic clinic, or the hematology oncology clinic, or gyne clinic that half day instead. But it's just a half day, which is basically 10% of the work week, they go to clinic no matter what. Game changer.
I could play a counterpoint to this. I tend to really favor a DR heavy first 3 years. I think there is a lot of people that still go out in the clinical world who are doing a combined job. So I tend to not care if they're keeping up their clinical skills in the first 3 years. I think that they need to focus on the DR in preparation for passing that core exam. So I kind of take the pressure off them, and I don't necessarily think the IR residents need to be excelling in the first 3 years, and then they need to be ready to hit the ground running in that beginning of their 4th year, and have a heavy immersion for those final 2 years. That's just how we do the program there. That's been based on feedback from our residents that want to have a good focus on DR and prep for their core exam at the end of 3rd year.
So what we do is we focus definitely on learning your core. We test them yearly on the in-service exam and rotationally, so you keep on top of their volumes and imaging. And so we also grill them on that so that they keep very high end on the imaging, right? We'll go over CTAs, coronaries, I'll kind of grill them on the liver. So they actually look at a lot of imaging, right? I look at liver imaging, do LIRADs in clinic. I do urologic imaging. They own that space even earlier. And we have them review all their imaging with the patient. We have them ultrasound in the clinic. So they're doing a lot of clinical imaging. But what I see is most of the graduates, most of my fellows early on, they had very poor clinical skills, worse than a lot of the students. And that is our weakness. That is our Achilles heel as a specialty. And we got to change that to protect the patients and public. So I think we have to shift our focus towards a clinical focus, just like Daughter said in 1968 at the American College of Surgeons. So I think that is where we have to transform. That is what Katzen said. That's what McNamara said, and we need to heed that voice. So I think we do need to change. I know it's going to be controversial, but I think this is the way the field is going to move.
When students are setting up away rotations, how might they kind of emphasize that clinic focus? Is that an integral part of your away rotations? And are there specific things that they should look for or ask for during away rotations? I'll direct this one to Dr. Luhar and Dr. Meisinger.
After
You want to
Quinn.
go first? We keep it kind of pretty free form. Whatever they're interested, they can ask for. We have a couple different sites. Generally, I like them to come by at least one site and and spend some time with me wherever I am. And that's just so that I get to know them a lot with the assistant program director, Dr. Chidonio. So we just make sure they get some time with the people that are making the decisions when it comes down to picking residents. So that's realistically probably what most med students want, and also some time to spend with whoever they want to write a letter. So obviously, usually the students want somebody to write a letter. So try to get them some focused time with specific physicians in our group. And it's usually the older physicians who have the bigger names.
Yeah, kind of similar to Quinn, we primarily put our visiting medical students into the hospital practice where they can see big cases and work with big names. We do try to make sure that each medical student has an opportunity to have a one-on-one teaching opportunity with the attending of that day for their room, making sure that med students aren't sharing rooms, although they're welcome to share cases. If it's a good learning opportunity, it's up to them. Also rotating through our cross-sectional procedure suite, because our DR program director is actually an amazing interventionalist himself, and that gives them some one-on-one time with him as well. I do think it is important to really take that time to get to know not just the attendings, but to really take time to, cooperate with and work well with the nursing staff and our technologists. Their opinions really do matter to us. With our residents, making sure that you're an asset and not making your presence there something that hinders the workflow, but really something that adds to the workflow, so that you're really contributing to the well-being of every member of the team while also pursuing your own learning. And then ideally, while they're with us, they would have an opportunity to either start on a project or start a relationship that may lead to a project down the road. So we have an opportunity to have a longer relationship with them, see how they're able to set themselves up for success when it comes to working on a project. So we can better envision how they would, fit into our culture and into our residency experience if they were to join us as a resident.
In terms of preparation, SIR has a bunch of great resources. Are there any other ways that someone can prepare ahead of time for an away in terms of what you referenced, Dr. Luhar? Are there any specific resources that you would like to highlight?
Yeah, I think that at many institutions, there's a strong network of people who came before you who have gone into field like IR that you're interested in. So certainly if you know anyone either at the institution who's rotated through the institution, tips and tricks, even little logistical ones like knowing where the cafeteria is, knowing what to expect on the first day can all be super helpful. Making sure that you bring with you some sort of a pocket resource. So if you have a question, you have an opportunity to quickly look something up. Making sure you're taking the time to read on the case the night before. And if you need something, to know how to, respectfully ask for it. So if you don't have access the first day to what the cases are for the next day, ask somebody for help. Just really making sure that you are setting yourself up for success, whether that means knowing where to get on day one and knowing how to ask questions in an appropriate fashion with a group of people you may not be totally comfortable with and who may not be invested in you yet. And then making sure that you bring adequate resources, whether it's as small as a granola bar and a bottle of water, because you don't know when you're going to eat, because you don't know what the schedule is going to look like for that day, to maybe a pocket interventional hand guide. So you have an opportunity to look up some of the basic questions rather than asking every question that you might have, and making sure that you're limiting your questions to educated, interesting ones. So you're provoking a discussion that makes you look like a sophisticated practitioner, as opposed to asking a basic question that could have been easily answered by a Google search.
Yeah, I agree with everything she said. Know the faculty ahead of time. do some reviews, so know who the program director is. That's probably should go without saying, just so you can at least interface with them. And then 2 is just read up the night before. You're not going to know the cases, the ins and outs, so at least do a little bit of history review, particularly the outpatient cases that are booked for the next day. And then the final thing is just be on time.
And Dr. Cooper, I'm seeing in the chat a shout out for your book. Can you explain to us what this book is and how people might find it, what is covered?
Yeah, it's actually Shantani's book, but I was the final author mentor. But it's called Pocketbook of Clinical IR, and it was aimed for medical student level, so it's not a huge comprehensive textbook. It can easily be completed on a rotation, and it just kind of gives you a little bit more of an insight as to where IR fits in with the other clinical specialties, why those patients may have been referred down. I feel like it's just a better resource for on your first rotation who's trying to get an idea of where everything fits together. There are other more comprehensive textbooks you can use if you're looking up specific cases. And Ken DARPA is a good one. But you're not going to read Ken DARPA front to back on a rotation. And if you do, kudos to you. I've never read it front to back. So yeah. Anyway, hopefully it answers that question.
In your experience,
just a little part for I think it's called Residency Essentials. It's put on by SIR. It's got a wealth of lectures and papers. And if you could start going through that during your residency, I think it's helpful.
Yeah, I think these books are all good, like Playbook, our Playbook by Nikki Keefe's great. Cooper and Laura Pondy's textbook is a great one as well. Kandarpa's got some good pearls. There's some good stuff on the RFS YouTube site that also gives you some guidance. And I want to kind of echo what Dr. Meisinger said. It's very important to be on time, right? If you're there after the faculty is scrubbed in on a case, not a good look. If you're there and you don't know the patient's history, not a good look, right? Then you maybe don't even scrub in, right? So you want to be there scrubbed in. And if you're rude to the scrub techs or x-ray techs or nurses, terrible look. If you are not a good team player with your co-students, not a good look. So these are all things where we're and other residents and the nurses and techs and the scrubs and the secretaries are paying attention to. So really, do you play well in the toolbox or in the sandbox? If you don't, it's not going to go well, right? So there's a competitive specialty. It's not a backstabbing specialty. We're very friendly with one another. We may agree to disagree, but we still are all aligned in the passion for clinical VIR, right? So those are kind of key pearls that I would advocate that you to take to your future rotations. And there are guides that the RFS has developed per site, what works and what doesn't. Then Lindsay Matchlock, one of our former students, developed, so it's available to you as a resource.
in your opinion, how is the program signaling and geographic signaling influencing the way that you select your candidates?
Also, as an FYI, the supplemental application that was done last year will be going away. This will be integrated into one kind of application, so there will be a section for this. But I loved it. I thought it was great to see. It helped kind of trim down who really wants to be in certain areas.
Right,
Yeah,
so-
Kyle, what are your thoughts? I mean, or anyone else, RD, or what are your thoughts on this new process?
Sorry, I was chatting so much. What was the question?
No, just about the preferences and whatnot, geographic and location.
I think we're a California school, obviously, and we tend to favor applicants that are from the area, but I don't discriminate against people from outside our geographic area necessarily. I felt like I was discriminated against as somebody from Michigan who'd only trained in the Midwest and who really wanted to go to California. Didn't get very many interviews outside of the west of the Mississippi. So there are definitely some programs that really do use that as a discriminator. So I think in those programs, if you really want to get to a place outside of your geographic area, I think we need to show a little extra interest, whether that be personalized personal statements or, weight rotations, things like that, to make sure that they're, because it's so easy to shotgun apply now, especially with virtual interviews.
Yeah, I was going to say
100%.
the same. Because of virtual interviews, it's hard to know who is serious about coming to your place, especially when they're from, I'm in the Northeast. It's hard if I see somebody from California, Kyle's neck of the woods. Kyle is like my brother, by the way. We trained together at MCVI, but it's hard to know somebody coming from his neck of the woods and interviewing at mine. I just always wonder how serious they are, because virtual, it's easy, right? You don't have to travel, you don't have to buy a plane or anything, a plane ticket. So I do agree that if they're able to mention something of why they would like New York, their families here or whatever, they grew up here, it's nice, because then I can tell if they have a genuine interest.
I may be a little bit of a voice of the minority, but I will say that we are so proud of, not only our institution and the program that we have, but also our stunning location, just, 20 minutes to the beach and 2 hours to the mountains, that we don't really necessarily count on signaling as much as maybe another program would to indicate interest. We don't really take it into account because we're reviewing these, applications holistically. That said, if you do get to the interview stage, I think it is important to kind of signal the interest in the conversation by showing that you've thought about what it would mean to move to a new city if it's not the place you're already living, or to know a little bit and have done your research about the institution if it is a place you are truly interested. We do care to know that you have thought and wrapped your head around what it might mean to move to LA, because that's part of what's going to make you a great resident. Somebody who has planned what a large move might mean, who has thought about how they're going to integrate into the residency, who has already identified things that may make them feel supported or happy or make them a better resident. So it is important to think these things through, but the actual column where it says signal yes, no, urban yes, no, I don't know that we think about that so much. Really, what we care about is that after reviewing your application holistically and after meeting with you in an interview, we think you're the right candidate for our program. And some of that does take that interest into account, but not in so black and white a way as the signal.
I think there are a lot of questions in the chat or comments about virtual. I think that was something that for this interview season, we had to decide as a group. There are definitely advantages to being in person versus virtual. The thing that my associate program director, Adrian Gonzalez, and myself had to consider, and actually he ultimately made the decision because he was in charge of the interviews, is there's always an issue of access. So with virtual interviews, it's not expensive. And so if you're, we're trying to be more inclusive, you have to worry about a woman who is in charge of childcare. She has to look for childcare responsibilities and so forth in order to travel to do her interview. So, and there are single fathers that also have to make those decisions. So for us, we have stayed virtual this year. It was for us an issue of access and trying to be most inclusive. I would say that the benefit of a in-person interview is that I get to know that how interested you are because you physically came, and you get to see the different facilities, which I do think are a plus and would draw people. There are advantages and disadvantages of both approaches, but for now, we have decided to remain virtual.
Yep, it's going to be virtual, and that kind of comes down from leadership. Somebody put in there saves money. That is totally correct. And I think if you're going to spend some money, do it on an away rotation, a couple away rotations at some specific places you want to go.
In the last 10 minutes, I thought we'd kind of direct questions about the future of IR and the future of IR residencies. We've seen this morning that there's a lot coming down the pipeline, anything ranging from percutaneous spinal lifts, for example. This type of technology and kind of specialization by organ system is kind of expanding what IR can do. Do you anticipate any curriculum changes in the scope of procedures? What are people within programs kind of thinking about and discussing in terms of training once you're in the program?
I think the fundamental shift coming down the line is IR breaking off from DR, kind of like RAD-ONC did. Eventually, that kind of allows us to do a model similar to Geogy at the LA Kaiser, where if you're not financially tied to the diagnostic residency program or diagnostic department, then you have some more flexibility when it comes to what you do with your IR residents. So if there is an eventual separation of us away from DR, I think that's going to be the biggest fundamental shift going forward. Is an IR, it's his own department, kind of like urology with surgery, orthopedic breaking away from surgery. That's going to allow us to kind of have our most flexibility as a residency. So when that happens, OHSU already did it. So they've set the standard probably nationally for the rest of the academic departments and divisions. So that's what I see as probably the biggest change going forward if that happens.
I also do wonder if there's going to be more of a push for an IR fellowship. At least at my institution, they're trying to understand. They don't understand when they see somebody coming in as just graduated from a residency, but everybody else is being employed after a fellowship. Should they enter at a lower salary? There is a poor understanding of this transition from IR fellowship to IR residency, and I do think that there's going to be a growing push towards an IR fellowship where you can be more specialized in, say, vascular or oncology or so forth.
Yeah, and I wonder, as an aside, we're looking at that as well as we integrate, kind of the thing, including fourth years too. What I've been impressed by is our fourth years are coming in with so much knowledge, right? They've done 3 or 4 BIR rotations, vascular surgery, ICU, and then surgical internship where they're doing more endo stuff. So they have a lot of skill set already jumping into our PGY 2-year. So they're just different than we've historically had. And as they go into their 6th year, PGY 6, I'm almost like, hey, you may need to do an away subspecialization and things either we're not doing, like some of the complex MSK intervention screws or whatever, maybe kind of unique or go abroad. So I think if we truly integrate it and they show competency in all aspects of kind of VIR, then that should be a reality. Whether it be neurointerventional or peds interventional or what have you. I think that may be one consideration, or you extend the training further. That's another option.
Yeah, I mean, the fellowship, go ahead.
Yeah, I guess I was wondering if there are discussions in place to have those type of fellowships, such as an MSK fellowship, hepatocellular, or I guess interventional oncology fellowship, and what that kind of looks like.
Great question. So actually for those of us in the APDIR or the program directors of IR Association, that's going to be one of our topics at SIR at the business talk, and then we'll probably touch it more on at AUR. But Mount Sinai did a neurointerventional program. And so after IR, that is is going to be set up as a formal one. I think there is interest in an MSK one, as you mentioned, something that's formal, ACGME accredited outside of neuro, and then peds, and then potentially interventional oncology down the line. So all of that there is some interest there. It's just how to deal with that when it comes to ACGME versus informal fellowships versus match and all that stuff. So a lot of kinks to work out before these things go live.
Yeah, to get ACGME or ABMS certification as a subspecialty CAQ, because historically interventional radiology or vascular IR was a CAQ, which is certificate of adequate qualification. So it's subspecialty certificate, kind of like peds radiology, neuroradiology, and I forget the other ones. But anyway, then in 2012, September, that's when the ABMS made it the 37th specialty, a primary specialty equivalent to internal medicine, ER, pediatrics, et cetera. And so that's why interventional radiology became a new specialty then in 2012. Subspecialty certification for formal sampling has to go through ABMS. The informal stuff, kind of like the neurointerventional, for example, is a 7-year pathway that the CAST, which is kind of a governing body for neurointerventions, has okayed, where you're integrating throughout the training. So you're adding some neuro ICU, more advanced kind of stroke neurology and things of that nature during your 7 years of training. But it's a 7-year dual certificate, or triple certificate, I guess, neurointerventional, peripheral interventional, and vascular interventional, or imaging. The other possibilities, there are some kind of IO special fellowships out there that where you add a little bit of RANOC or this or that are, again, not ACGME certified, but unofficial. And there's advanced endovascular fellowship that Rush has as a 1-year added time. And then musculoskeletal fellowships like Doug Beal has, which is, again, unofficial, but people are doing where they can do anywhere between 3 months and a year of additional training, but it's not a formalized fellowship. So these are some of the options that are currently existing out there that are available. And then finally, people are going abroad for additional training. They've historically done that at places like Leipzig in Germany for vascular training and so on and so forth. So there are a few things that have historically occurred and are going to continue to occur, but formalization hasn't, quote unquote, no pun intended, formally occurred.
Yeah, we have an IO fellowship at Sloan.
Yeah. Lots of work coming down the pipe on that stuff.
Yeah, what we're at now and where we're going to be in 5 to 10 years is going to be fundamentally different. And, you know, as I talk to more and more students and residents, you guys are going to be the voice of change. It's not going to be us on the stage. We're going to be kind of grandfathered out of this, right? It's you. It's your future, right? You guys got to be the ones who change it. Daughter and Katz and others can kind of give you the guide, but it's on you to make the field what you want it to be. That's what's special about it. It's a new specialty. We're going to be in tremendous transition, a lot of debate, right? Just like if you read the radiation oncology, I would go to their website, Astro, look how they went from therapeutic radiologist to Astro, American Society of Therapeutic Radiation Oncologists, what that transition was, why it occurred, read the history. There's a lot of parallels, okay? And I think you'll start to see that as well. But read it. They've done a better job than we have in establishing their history. And I think we can learn from their society on how they've documented, demographed it from a historical standpoint. We haven't done that. We should. I mean, I showed you a little snippet of where we were 1960 or 1953 to 1964 and the number of amazing individuals. Some you're going to hear today, like Ann Roberts, right, who developed a catheter and changed the field of medicine forever, right, in various ways. You're going to hear these kind of legendary people that we need to chronicle their history, right? And so there's a lot of amazing talent that's been there historically, and you're going to hear some of it today. All right. And what a great panel. And we're going to continue this discussion at APDIR. Both at the SIR national meeting, which is a little tricky, but also at the AUR/APDR meeting. And so we'll have a lot more debate and a lot more discussion. And we're going to learn a lot of things from kind of the group talk and group speak. And we should encourage everyone who's a program director to communicate on the SIR SIR Connect program director panel to bring up some of the issues that are occurring regionally and nationally that I've been hearing kind of scattered. Thanks, everyone.